doubtful benefits, and often they are either under or over investigated. So, for this topic, there is no better person than our first speaker for the day, Dr. Akash Shukla, to guide us on this very important clinical scenario. I'll give a brief introduction about Sir. Sir is one of the most prominent gastroenterologists and hepatologist in our country. He is currently head of department of gastroenterology department in KEM Hospital, Parel, and he is also a director and a consultant hepatologist at HN Reliance Hospital in Mumbai. He is currently he's actively involved in liver transplantation program and also state advisory committee member for organ donation and transplant, Government of Maharashtra. Sir has done a lot of research work on a wide range of topics in gastroenterology and hepatology. He has a special interest in vascular liver disorders like Budd-Chiari syndrome, and he has a lot of publications on this and many other topics to his credit. Now I request Dr. Akash Shukla to come on dais and guide us on the first lecture, which is Deranged LFTs and Simplified Approach for Quick Diagnosis. And to chair this session, I invite Dr. Sushil Indoria, Dr. Sachin Wani, Dr. Prashant Jadhav, and Dr. Bipin Mahale to come on dais, please.
Good morning, everybody. At the outset, I must thank Dr. Bhandari, a very dear friend and very dear colleague. We have worked together for a long time, and it's a pleasure being here once again in Thane. And in the next 15 minutes, I'll take you through how do we approach an abnormality in liver function tests. So I bring greetings to you from KEM Hospital and Department of Hepatology at Sir H.N. Reliance Foundation Hospital. This is a department which we just formed 6 months ago. And I'm happy to tell you that we have already done over 50 liver transplants in less than 6 months with over 90% of success, including simultaneous liver-kidney transplant, ABO-incompatible transplant, pediatric transplants. And we have a gamut of stars who run the show. So what I'm going to discuss in the next 15 minutes is the first thing, how do we classify these liver function tests? How do we approach abnormalities of bilirubin? Then we'll discuss about SGOT, SGPT. Then we'll discuss about alkaline phosphatase. Then I'll briefly discuss about what are something called as non-conventional liver function tests and what is the diagnostic approach finally to incorporate all the tests. So the first thing is liver function test is really not a liver function test. It's a group of tests which each one of these have a different role, and therefore the more appropriate term than LFT is actually liver biochemistry. Because there are tests which look at the detox function or the excretory function of the liver, and those are the serum bilirubin or the urine bilirubin and blood ammonia levels. So bilirubin both for acute and chronic disorders, and ammonia more for acute liver failures. The second group of tests do not really look at the liver function, but they look at how much damage is going on in the liver. And these tests are the SGOT, SGPT, what we now call as AST, ALT. Then the third function of the liver is to form bile and to ensure flow of the bile. So the tests which reflect the flow of the bile from the liver into the bile ducts or within the bile ducts to the duodenum, and these are alkaline phosphatase and gamma GT. And then the fourth function is to synthesize proteins. So the fourth group of tests tell you the ability of liver to form good proteins in the body. Which are these? Serum albumin, which is for the long term, and coagulation factors like prothrombin time, INR, which are useful for short term as well as for long term functioning. Therefore, when we look at a LFT or a liver biochemistry and you find something abnormal, you want to classify that LFT into one of these 5 groups. What are these 5 groups? Isolated hyperbilirubinemia, that is, only bilirubin is elevated, rest of the LFT is normal. Or chronic isolated transaminases rise. What is this? Only SGOT-PT is elevated, rest everything is normal. All of us have faced these reports. Anybody who has not seen these reports? Good. Third is acute hepatitis. Acute hepatitis is enzymes going very high in hundreds or thousands, bilirubin following later on. So initially you will have enzymes going to 500, then 1000, then 2000, 3000. Then enzymes come down to 2000, 1000. The bilirubin keeps on rising. Then the fourth is cholestatic hepatitis. Cholestatic hepatitis is the one which is most difficult to diagnose and treat. Here, the SGOT-PT is also slightly increased. The bilirubin is also slightly increased. Alkaline phosphatase and gamma GT is also slightly increased. So this is the group of disorders, and each one of them can be in different proportions. Sometimes you will have normal SGOT-PT, but very high gamma GT. So this is something called as cholestatic hepatitis. And finally, you have something called as pure cholestasis. Pure cholestasis in early stage is only alkaline phosphatase and GGT increased, rest of the LFT normal. Later on, you also have a mild increase in bilirubin with normal SGOT-PT. So this is one of the 5 LFTs abnormalities you have to try to fit your patient into. So let's start with the first thing, and that is bilirubin. So the first thing which confuses me when I see the report right from my UG days is some tell you this is direct bilirubin, this is total bilirubin, some tell you this is conjugated bilirubin, some tell you this is unconjugated bilirubin, indirect bilirubin, delta bilirubin. What does it all mean? And what is the significance for us? So the first thing we have to understand is direct and conjugated doesn't mean the same. Total bilirubin is total. You have to then look at, you have to stop calling direct bilirubin now. Direct bilirubin was, remember, if you remember your first MBBS, we used to do that Vandenberg reaction in the biochemistry, which used to look at the solubility of the bilirubin. So that has become obsolete. With the now onset of dry biochemistry, which is what we should be doing today, we look at conjugated and unconjugated bilirubin. And almost 100% of bilirubin in the body normally is unconjugated. If you find more than 15% of unconjugated bilirubin, then it is abnormal. And you need to investigate further. So this is the first thing which we need to see. But how do we know clinically whether conjugated is increased or not? That will come only in the report. How do I confirm whether my lab has given the right report or not? So if you have a patient whose conjugated bilirubin is high, his urine will always be dark. If you have a patient who comes to you with jaundice, but the urine color has not changed, urine is not dark yellow, then this is not a liver-related jaundice. Then this is either Gilbert syndrome or hemolysis or reabsorption of a large hematoma, or the RBCs are breaking down, something like that. So a patient with jaundice but normal color of urine is not a liver related. This is the first thing that we learn. So these are the patients where you should look for non-liver causes, look for hemolysis, ineffective erythropoiesis, and Gilbert syndrome. How do we really approach these two? The first way, when you find a patient with just increase in unconjugated bilirubin, is you ask for a CBC, see whether there is anemia or not. You ask for a urine bilirubin, urine urobilinogen. Urine urobilinogen is negative. And CBC is normal. There is no anemia. There is no hematoma. There is no trauma. You can safely diagnose this patient to be Gilbert syndrome. If you find anemia, you must ask for reticulocyte count, peripheral smear, and hemoglobin electrophoresis to identify what is the cause of this hemolysis. Gilbert syndrome is extremely common. Around 3% of people in Mumbai have Gilbert syndrome. So what is Gilbert syndrome? It is just elevation of the bilirubin because there is slight deficiency of an enzyme called as UGT1A1 in the liver. Usually it doesn't cause any problems unless the patient goes on chemotherapy and patient receives irinotecan or some similar drugs. In those patients, it can cause severe granulocytopenia and other complications. So that is the only implication of Gilbert syndrome. By itself, it does not cause any damage to the liver, and all you need to do is reassure the patients. Now let's come to the more difficult part, and that is conjugated hyperbilirubinemia. That is, this bilirubin is increased either because of the liver or because of the problem in the bile ducts. So you have on one hand rare disorders like hereditary disorders, Dubin-Johnson, Rotor syndrome, which are again extremely rare. So if you don't know about them, it is absolutely all right. They will be presenting in young people, first or second decades of life. Bilirubin is very high. Other LFTs are absolutely normal. And again, these patients, because of their high bilirubin, will get referred to tertiary care centers and need to be managed there. Then you have patients who have got bilirubin with intrahepatic cholestasis. What does it mean? That the bile is being formed in the liver, but the bile cannot come out from the liver cells into the bile ducts. That is called as intrahepatic cholestasis. So this is something which is clinically very similar to obstructive jaundice, but without any obstruction in the bile ducts. This can happen in alcoholic hepatitis. This can happen in all acute hepatitis like hepatitis A, hepatitis E. It can happen in drug-induced hepatitis and rare cholestatic disorders like primary biliary cholangitis or primary sclerosing cholangitis, PFIC, BRIC. These are all rare disorders. Remember, you can get cholestasis in any cirrhosis. Anybody who has got advanced cirrhosis can have intrahepatic cholestasis. When you have these patients, you must always first rule out an extrahepatic biliary obstruction. It could be because of stones, it could be because of malignancies, and the best test as the first line to differentiate whether you are dealing with jaundice because of obstruction in the bile duct or because of intrahepatic cholestasis is a simple test of ultrasound. On an ultrasound of the abdomen, if you find dilated intra-IHBR, that is intrahepatic biliary radicals, dilated CBD, hugely distended gallbladder, any of these findings, then we are dealing with an obstructive jaundice rather than dealing with a intrahepatic cholestasis. But if you don't have any of these findings, then you are in all probability dealing with an intrahepatic cholestasis, and therefore you should look at and investigate for all intrahepatic causes. Now, two causes which I would want to bring to your notice for elevated bilirubin. One in OPD setting and the second in a ICU setting. So when you have a patient in the OPD setting who comes to you with isolated bilirubin and you don't find any other cause, always look for drugs. A lot of drugs will cause just mild elevation of bilirubin. And unless we know that list, we will make mistakes. In the ICU setting, the most common cause of rise of bilirubin is actually sepsis. So whenever a patient is in sepsis, you will find the bilirubin going to 2, 3, 4. So these are the patients where you take care of the sepsis and the liver will come back to normal. So there you don't get worried about the bilirubin. Very often I get references, please see this patient has got elevated bilirubin, patient is in sepsis, pneumonia. All you need to do is treat the pneumonia, treat the sepsis, and the bilirubin will come back to normal. Let's come to SGOT, SGPT before we go on to the list of the drugs that we have to be careful about. Now, what is normal? Now, this is the biggest quandary that is there. In anybody, how do you say what is normal? And the biggest dilemma in SGOT-PT is how much is normal? So if you look at different labs, some labs in South Bombay give a value of 64 as upper limit of normal. There are certain labs which will give you value of 45. Then there are certain labs which give you a value of 40. Then there are certain labs which will give you 32. So why all this confusion? This confusion is because how have we defined normal? So traditionally, anything that is present in the 95% of the population, you leave the top 2.5% and the bottom 2.5%. And what is present in the middle 95% is taken as normal. The problem with such a thing is, what if the population has a disease prevalence of 20%? Then a lot of people who have actually abnormal values will be labeled as normal. This is what happened while defining values for SGOTPT. So these values of 65 were when in 1940s and 1950s tests were being done. When we didn't know there was hepatitis C, we didn't know there was something called as non-alcoholic fatty liver disease. So that time 65 values came. Then people did more tests and realized, okay, no, hep C has come. So the values changed to 40. Then now today when we have an idea of NASH, non-alcoholic steatohepatitis, we have redefined what is normal. Today, for a normal for a lady is 19. SGOTPT should be less than 19. And for a man in Western India, a normal SGOTPT is less than 24. This is data from Mumbai, from 35,000 people population, healthy population. Based on that, this is the value that we have now arrived. So 19 and 23. Anything more than this in a lady or a man should be considered as abnormal. But we never react to one abnormality of reading. If you have one report of 25 or 27 or 30, you don't start investigating this patient for everything. Because a common cold, a viral illness, a intake of NSAIDs, intake of paracetamol for 2 to 3 days, all this can cause increase in SGOTPT. So you will always repeat abnormal SGOT, SGPT after 4 weeks. And if you find that 2 reports which are showing abnormal SGOTPT, then we must definitely investigate this patient. So what does this basically tell you? A high SGOT, SGPT. A high SGOT, SGPT basically tells you that the liver cells are dying more rapidly than they should. When it is mildly elevated, that means the quantum of cells dying are lower. When you are having a very high SGOTPT, 200, 300, that means more cells are dying. When it is in thousands, even more cells are dying. Out of these two, SGPT is actually much more specific for liver diseases, but can also be increased in patients who have got myopathies. So don't do SGOT, SGPT if you have given intramuscular injection on the previous day, because that itself can cause a slight increase in SGOT or SGPT. So SGOT is present both in the cytosol and mitochondria, and therefore tends to be higher in all non-liver related diseases, especially like the heart diseases, skeletal muscles and blood. Before we got CPK, CPKI, TROP-T, TROP-I, we used to do SGOT actually for a myocardial infarction. For some of those who were practicing in 1980s, you'll remember, we used to send SGOT the next day when you suspected somebody to have a myocardial infarction. And when you found only SGOT increase, you would say, okay, this looks like a myocardial infarction. So all these things were done once upon a time. Of course, today we are much, much better off. But remember, when you have isolated SGOT increases, in addition to cirrhosis and alcoholism, which are the commonest causes, you must also keep in mind whether we are dealing with a cardiac disease, a myopathy, or a hemolytic disorder. Now let's come to the causes of elevated SGOTPT, and I've made it, this is how I remember. I have very limited sulci and gyri, very limited memory, very limited IQ. So I try to make things simple so that I can remember. So I have this A, B, C, D, E, F, G, H. So A is for autoimmune hepatitis, B is for hepatitis B, C is for hepatitis C, country medicines or celiac disease, D is drugs or toxins, E is alcohol, that is ethanol, F is for fatty liver, G is during growth spurts. This is another something which you have to remember. During growth spurts, you can have non-specific elevation of SGOT, SGPT. And that is again because the muscles continuously get torn. The cartilage is increasing, the ossification is happening, the muscles get stretched, and there's subclinical muscle injury, and you can get SGOTPT to be increased. And then H is hemodynamic disorders like congestive cardiac failure or Budd-Chiari syndrome. And finally, M is metabolic liver diseases and muscle injuries. Now let us look at the list of medications which can cause increase in bilirubin or increase in SGOTPT. Now this is a huge list, but I want you to focus on some of the drugs which we usually don't think of. paracetamol, the first one. So if somebody is taking paracetamol for more than 7 days or takes more than 2 grams per day, then that itself is sufficient to cause elevation of SGOT-SGPT. Amoxicillin clavulanic acid, so commonly prescribed. Almost every second patient, third patient with a sore throat gets a prescription of amoxicillin clavulanic acid, very often from a relative or a friend or from the pharmacist. Okay, rarely from a doctor. So what is a typical pattern of this coamoxiclav injury? The jaundice or the rise in SGOT-PT doesn't happen on the same day or within 5 days. It happens after 3 weeks. So if you have a patient who has come to you with jaundice and mild elevation of SGOT-PT, there is some cholestasis, you don't find a cause, always ask whether he had taken coamoxiclav 3 weeks ago. I have had my first acute liver failure was coamoxicillin clavulanic acid associated acute liver failure in a young 19-year-old nurse, student nurse. So it can go to that extent. It happens rarely. Doesn't mean that everybody with coamoxiclav will get. It is a rare thing. But because it is prescribed so commonly or taken so commonly, therefore you have to be aware that if a patient presents and you don't find any other cause, look for coamoxicillin clavulanic acid. Doesn't mean that you don't prescribe when it is indicated. You prescribe it when it is required. Amiodarone, extremely common. Today in elderly patients, when there's polypharmacy, patients are on so many drugs, amiodarone specifically in a patient who has got a predisposition for liver diseases, especially NASH, will cause elevation of transaminases. Heparin in the ICU setting is another common cause of mild elevation of bilirubin or SGOT-PT. Statins, we are all aware, but remember, statins are one of the safest drugs to be given in patients with NASH. So very often we are afraid. A patient with NASH comes whose SGOT-PT is 80 and 100, and this patient also has dyslipidemia. The question is, can you give this patient statins? The answer is yes. This patient will benefit with statins. Don't be afraid of giving statins in somebody with a fatty liver disease. The benefits are far, far, far more than the risks. Look at the other list of drugs, and those are the ones which we should avoid. Labetalol, very commonly used in pregnancy, very commonly used in patients with difficult to treat hypertension. NSAIDs, phenytoin, propylthiouracil, sulfonamides. And if you go to the right side, a lot of complementary and alternative medications. We know tenospora can unmask autoimmune hepatitis, and we have all seen these patients in the last 3 years. Whether the government acknowledges or doesn't acknowledge, we are all aware that it's a reality. Then illicit drugs, especially anabolic steroids, cocaine, ecstasy. But focus on one of the drugs amongst the herbs, senna. So commonly used in your laxatives, senna. Senna can cause increase in SGOT-SGPT. So remember, for all these drugs, it is not common to have elevated transaminases, but all of these can be the cause. And in a patient where you don't have any other cause, these are the things to be looked for. Now let's go to the other situation, acute hepatitis. Transaminases more than 1,000. What do you think of? The first and foremost is acute viral hepatitis. That is hepatitis A, B, or E. Any of these three can cause SGOT-PT to be more than 1,000. But if you have a patient whose SGOT-PT is 8,000 or 10,000, bilirubin is only 2 or 3, this patient is herpes simplex hepatitis unless proven otherwise. In these patients, don't even wait for the reports of HSV to come. Because if you treat this patient within 24 hours of elevation of transaminases, this patient has an 80% chance of survival. But if you treat these patients after 5 days, even with treatment, the chances of survival fall below 30%. So herpes simplex hepatitis is something which you should always keep in mind. Enzymes in thousands with minimal elevation of bilirubin. You start these patients on acyclovir. Don't wait for the reports. If the report comes negative, you can always stop. You have to just hydrate these patients. Then the other is drugs or toxin-mediated injury. Again, many drugs can cause this, and we are all aware of the retol. Again, with Retol, very common mistakes which I have seen in practice. The transaminases will not rise on second day or third day. The patient has taken Retol today. For next 2 to 3 days, he will be absolutely fine, except for mild vomiting. Those who have taken in very high quantities, on day 4, day 5, they will get cardiomyopathy. They will get hypotension, shock, cardiogenic shock. It is only after day 5 that you start seeing elevation of transaminases. So day 4, day 5, the SGOT-PT starts increasing. And the liver failure will set in after day 5 to day 7. Very often, these patients get admitted, they get observed for 48 hours, everything is normal, you discharge them, and they come back with liver failure on the 4th day. So first 2 days, nothing is going to happen to them. And the problem will start only after the 3rd day. So this is something which we have to keep in mind when we manage patients with Retol. Then the other rare causes are acute biliary obstruction. Suddenly a stone comes and gets impacted in the bile duct. Before the GGT and alphas increase, before the bilirubin increases, the SGOT-PT can actually go into hundreds. It can be 700, 800, sometimes even thousands. Then ischemic, which is again in the ICU setting, patient in hypotension, you will have enzymes in thousands. You may also have associated acute kidney injury and the creatinine goes up. So when SGOT-PT goes in thousands and the creatinine increases suddenly to 3, 4, we know that we are dealing with hypotension or hypoxic ischemic hepatitis. Moderate elevation, that is between 250 to 1000, can be because of viral hepatitis, it could be drug-induced hepatitis, autoimmune hepatitis, Wilson's disease, and all the causes of severe elevation can also cause moderate elevation. Mild persistent elevation less than 250. Here you have to think of alcoholic hepatitis. So other than hepatitis B, hepatitis C, and NASH, 4th cause is alcoholic hepatitis. So these are the 4 commonest causes: Hep B, Hep C, NASH, and alcoholic hepatitis. If you have a patient whose SGOT-PT is more than 400, even if this person is taking alcohol, you have to still look for other causes. We have had patients who have been drinking heavy doses of alcohol. They came to us with jaundice and we found autoimmune hepatitis. We have had patients with severe alcohol consumption coming to us with jaundice and we have found lymphoma of the liver. So whenever the enzymes are more than 400 in an alcoholic patient, you have to look for other causes. Don't label this person as alcoholic hepatitis. And then you have other causes like Wilson's disease, autoimmune hepatitis, cholestasis, and malignancies, which can cause mild elevation of SGOT, SGPT. If you have SGOT only increased, SGPT is normal, first confirm that it is from liver only and not from muscle or from the heart. Second is, it could be because of alcohol, and third, it could be because of drugs. Or 4th would be Wilson's disease, but that is extremely rare. If both are increased, SGOT-PT, and SGOT is more than SGPT, then you have to think of either alcohol as the etiology or the patient has already developed cirrhosis. If SGPT is more than SGOT and both are elevated, then you have to think of NASH or chronic viral hepatitis. Now let's come to the last group of disorders, and that is alkaline phosphatase. Now alkaline phosphatase is non-specific. It is not only from the liver but also from bone, liver, kidney, intestine and placenta. But it's a very sensitive test for biliary obstruction, whether within the liver or in the bile ducts. But because it is non-specific, so you are never sure whether the alkaline phosphatase is increased because of liver or because the patient has osteoporosis or because the patient has got a chronic kidney disease or because of even intestinal infection. So what we do is we always ask for a gamma GT along with it, gamma glutamyl transferase. So GGT. If both are elevated, then we know we are dealing with a liver disorder. The problem is alkaline phosphatase takes 2 days to increase after a biliary obstruction. So if today the biliary obstruction takes place, the acute obstruction, the alkaline phosphatase will not be high tomorrow. It will take at least 48 hours. And after that, it will start rising. So in an acute biliary obstruction, you don't wait for alkaline phosphatase to increase. So patient who comes to you with severe acute pain in the right upper quadrant, you always ask for an ultrasound to look for a biliary obstruction, even if the LFT is normal. Then if somebody has got alkaline phosphatase elevation for a long period of time, last 2 months, 3 months, 4 months, what are we dealing with? We could be dealing with an infiltrative liver disorder, or with the classical example being tuberculosis of the liver or sarcoidosis of the liver, or we could be dealing with a chronic biliary obstruction. It could be something like a biliary stricture, like a hilar cholangiocarcinoma, or a lower cholangiocarcinoma, CA head of pancreas. Then you may be dealing with the intrahepatic cholestasis, all of which causes we discussed. And finally, you can have non-hepatic causes of isolated alkaline phosphatase elevation, like Paget's disease of the bone, osteoblastic bone metastasis, small bowel obstruction, and even pregnancy. Again, different units are there for alkaline phosphatase to look at the lab, whether they're using King-Armstrong unit, where 13 is normal, international units where it is 115 or 120, and there are certain kits which give 313 as the upper limit of normal. And if you find elevated GGT, then that confirms that it is of liver origin. But GGT is not something which is specific for obstruction or only cholestasis. GGT is a very useful test to do, and all of you have to be aware because it is not something which was taught to us when we were undergraduate students. So GGT increases in 3 situations. 1, in obstructive jaundice. Second, in anybody who consumes alcohol, even if there is no liver disease, the GGT will still increase. So GGT can be used as a marker for alcoholism. So you have a person who denies taking alcohol, you do LFT and you find elevated GGT, almost always he is drinking alcohol. And the third place where GGT is useful is in the absence of alcohol consumption. Somebody who is not drinking alcohol and you find elevated GGT, there is no obstruction, there is no alcohol consumption, then this is a marker of fibrosis and cirrhosis. So high GGT in a non-alcoholic, non-obstructed patient indicates advanced fibrosis. So these are the 3 situations where GGT is very useful. Now, coming to the last part, unconventional tests, lactates, which are extremely useful in acute liver injury. Patient who comes with acute hepatitis, if the lactates are high, this patient is going to develop liver failure. If the INR is high, this patient is developing liver failure. For chronic liver diseases, platelet count is also a part of LFT. A low platelet count, less than 2 lakhs, indicates advanced liver disease. So in a patient who has got fatty liver, you find a platelet count of 1,60,000, please look for cirrhosis in this patient. Send this patient for fibroscan and you will pick up severe steatosis and you will also find advanced fibrosis. So let's see what is the approach in these patients. You take a detailed history for the drugs, family history, alcohol, all these things. You look for history of drugs like NSAIDs, antihypertensive drugs, statins, antiepileptics. We always repeat LFT. Remember, we said that based on one abnormal report, we never investigate. The first set of tests in abnormal SGOTPT is hepatitis B and C. You look for metabolic syndrome, lipid profile, sugars, uric acid. If you still don't find, you go to the next level of tests. You look for Wilson's disease, you ask for ceruloplasmin, KF ring, urinary copper, and you look for autoimmune hepatitis. You ask for ANA, ASMA, IgG. But by itself, ANA or ASMA positive doesn't mean autoimmune hepatitis. The whole clinical picture and liver biopsy has to be taken into consideration. Then you may ask for IgM and IgA. If they are elevated, they indicate PBC or alcohol respectively. If you still don't find the cause, then you investigate for rare causes like occult hepatitis B, occult hepatitis C, rare metabolic disorders, metabolic congestive disorders of the liver like Budd-Chiari syndrome. So you ask for a color Doppler of abdomen where you specifically ask for Doppler of the hepatic veins, not just portal vein. So ask for hepatic veins and you'll pick up very often. Celiac disease. And if you're dealing with the cholestasis, then ask for AMA M2 for PBC, MRCP, and like we discussed, if ultrasound has not picked up, you are still suspecting obstruction, then you have to take help of Dr. Bhandari and do an endoscopic ultrasound. Liver biopsy is to be interpreted in terms of clinical and lab features and not to be done randomly. In the right patient, liver biopsy today also is extremely useful to establish the diagnosis. We no longer use it to stage the fibrosis, but we use it to establish the diagnosis in a lot of patients. So to summarize, my dear friends, we classify our lab abnormalities of liver biochemistry and we no longer call them the liver function tests. The causes are multiple, have to have a rational approach. Remember, you have to group the disorders into those 5 broad categories which we talked about, and based upon that, you make a diagnosis. Take a very careful history of drugs and alcohol, and liver biopsy has to be interpreted with clinical and laboratory parameters. Thank you very much, and be happy to have any questions.
Thank you, Dr. Akash Shukla, for such a well